We are starting our lecture with conjunctival inflammation. We are going to discuss anatomy, histology, and clinical features of conjunctival inflammation. Starting with anatomy, the conjunctiva is a transparent mucous membrane that lines the inner surface of the eyelids and the anterior surface of the globe, terminating at the corneoscleral limbus. It is richly vascular, supplied by the anterior ciliary and the palpebral arteries. There is a dense lymphatic network with drainage to the pre-auricular and submandibular nodes corresponding to that of the eyelids. It has a key protective role, mediating both passive and active immunity. Anatomically, it is divided into the palpebral, corneal, and bulbar conjunctiva. The palpebral conjunctiva starts at the mucocutaneous junction of the lid margin and is firmly attached to the posterior tarsal plates. The tarsal blood vessels are vertically oriented. The corneal conjunctiva is loose and redundant. The bulbar conjunctiva covers the anterior sclera and is continuous with the corneal epithelium of the limbus. Radial ridges at the limbus form the palisades of Vogt. The likely reservoir of corneal stem cells. The stroma is loosely attached to the underlying Tenon's capsule, except at the limbus where the two layers fuse. The plica semilunaris is present nasally, medial to which lies a fleshy nodule consisting of modified cutaneous tissue. Next, we will be discussing histology. First of all, epithelium, which is non-keratinizing and around 5 cell layers deep. Basal cuboidal cells evolve into flattened polyhedral cells, subsequently being shed from the surface. Mucus-secreting goblet cells are located within the epithelium, being most dense intranasally and in the cornices. The histological picture is shown here in the figure. This superior surface is the epithelium. Next is the stroma or substantia propria, consisting of richly vascularized loose connective tissue. The accessory lacrimal glands of Krauss and Wolfring are located deep within the stroma. Secretions from the accessory lacrimal glands are essential components of the tearfilm. Conjunctiva-associated lymphoid tissue or CALT is critical in the initiation and regulation of ocular surface immune responses. It consists of lymphocytes within the epithelial layers, lymphatics, and associated blood vessels, with a stromal component of lymphocytes and plasma cells, including follicular aggregates. Next, the most important part of our lecture would be the clinical features of conjunctival inflammation, starting with the symptoms. Now, non-specific symptoms include lacrimation, grittiness, stinging, and burning. Itching is the hallmark of allergic disease, although it may also occur to a lesser extent in blepharitis and in patients with dry eye syndromes. The visual acuity is not usually affected. Significant pain, photophobia, or a marked foreign body sensation suggest corneal involvement. Now, there can be different types of discharge as it is illustrated in the table here. Watery discharge is composed of a serous exudate and tears and occurs in acute viral or acute allergic conjunctivitis. Mucoid discharge is typical of chronic allergic conjunctivitis and dry eye. Mucopurulent discharge typically occurs in a chlamydial or acute bacterial infection. Moderately purulent discharge occurs in acute bacterial conjunctivitis, and severe purulent discharge occurs in gonococcal infection. The next feature would be conjunctival reaction. Hyperemia, that is diffuse, beefy red, and more intense away from the limbus, is usually a factor in bacterial infection, as it is shown here in the picture. The first picture, you can see the whole hyperemia, which is away from the limbus. And it should be distinguished from the ciliary injection of iridocyclitis. Next are hemorrhages, which may occur in viral conjunctivitis when they are often multiple, small and discrete, or petechial, and severe bacterial conjunctivitis when they are large and diffuse, as they are shown in this picture, large and diffuse hemorrhage, which is suggestive of a bacterial infection. Chemosis or conjunctival edema is seen as a translucent swelling which may protrude through the eyelids. Acute chemosis usually indicates a hypersensitivity response, for example pollen, but can occur in severe infective conjunctivitis. Subacute or chronic chemosis has numerous causes, as is illustrated in the table here. The picture here depicts chemosis. You can see the edema of the conjunctiva in the whole area. Now, local causes include thyroid eye disease, chronic allergic conjunctivitis, ocular or eyelid surgery, or in cases of trauma. Increased systemic vascular permeability occurs in cases of allergic conditions, meningitis, and vasculitis. Increased venous pressure, for example, in cases of superior vena cava syndrome or right-sided heart failure. Decreased plasma oncotic pressure occurs in nephrotic syndrome. Next, we'll be discussing membranes, which is another conjunctival reaction. Now, pseudomembranes consist of coagulated exudate adherent to inflamed conjunctival epithelium, as it is shown here in this figure. These can be peeled away, leaving the underlying epithelium intact, as opposed to a true membrane, which involves the superficial layers of the conjunctival epithelium, so that attempted removal leads to tearing. The distinction between a true membrane and a pseudomembrane is rarely clinically helpful, and both can leave scarring following resolution. Causes include adenoviral conjunctivitis, gonococcal, and some other bacterial infections, streptococcus, Corynebacterian diphtheria, ligneous conjunctivitis, and Stevens-Johnson syndrome. In the second figure, you can see the scarring here following the removal of the membrane. Our next feature is infiltration, which represents cellular recruitment to the site of chronic inflammation and typically accompanies a capillary response. It is recognized by loss of detail of the normal tarsal conjunctival vessel, especially on the upper lid, as it is shown in the figure, the first one. You can see that the normal details are lost. Subconjunctival cicatrization or scarring may occur in trachoma and other severe forms of conjunctivitis. Severe scarring is associated with loss of goblet cells and accessory lacrimal glands and can lead to cicatricial entropion. As it is seen here, there is severe scarring here in the slit. Our next feature would be follicles. Now, follicles can be multiple, discrete, slightly elevated lesions resembling translucent grains of rice, most prominent in the cornices, and especially lower cornice. Blood vessels run around or across rather than within the lesion. Histology, as shown in the picture, shows a subepithelial lymphoid germinal center here, with a central immature lymphocyte and mature cells in the periphery. Causes include viral and chlamydial conjunctivitis, paranoid oculoglandular syndrome, and hypersensitivity to topical medication. Small follicles are a normal finding in childhood folliculosis, as are follicles in the cornices at the margin of the upper tarsal plate in adults. The next would be papillae, which can develop only in palpebral conjunctiva and in the limbal bulbar conjunctiva, where it is attached to the deep fibrous layer. In contrast to follicles, a vascular core is present. Micropapillae form a mosaic-like pattern of elevated red dots as a result of central vascular channels. Now, macropapillae, which are less than 1 millimeters, and giant papillae more than 1 millimeter, develop with prolonged inflammation, as in cases of allergic conjunctivitis, which we will discuss later. Apical infiltrate or staining with fluorescent or the presence of mucus can be present with marked activity. Limbal papillae have a gelatinous appearance. Now the picture here shows macropapillae. In the corniceal conjunctiva. Histology shows folds of hyperplastic conjunctival epithelium with a fibrovascular core and subepithelial stromal infiltration with inflammatory cells. Late changes include superficial stromal hyalinization, scarring, and formation of crypts containing goblet cells. Causes include bacterial conjunctivitis, allergic conjunctivitis, chronic blepharitis, contact lens wear, superior limbic keratoconjunctivitis, and floppy eyelid syndrome. The most common cause of lymphadenopathy associated with conjunctivitis is viral infection. It may also occur in chlamydial and severe bacterial conjunctivitis, especially gonococcal and paranoid oculoglandular syndrome. The preauricular site is typically affected. Viral conjunctivitis tends to occur in epidemics and commonly causes preauricular lymphadenopathy. So now we conclude the topic here. If you like the lecture, please press the like button and subscribe to the channel. Thank you all.